Hi, good evening. Can someone tell me whether do you have any class right now? It's any class going on now? Anyone, please? Because I got so many message till 9:45. You have class like that. Yeah. Can anyone tell me? Is there any classes are going on now? Saranija, is there any class going on?
No, sir.
All right. Okay. So is it over, Hasruk?
Not yet, sir. Another 15 minutes or so, I think.
Okay, so here what I'm going to teach you are yeah, today I'm getting so many calls from students who got through the exam. Today we had so the results out, right? So even the first rank one is my student, and there as usual, all the students, most of them got through. All right. So what are we going to do is we are going to do the second paper. So first part, of course, I didn't send the paper to you. So what we are going to do, we are going to do the exam paper, exam online. Meantime, we'll do the answers as well. I'll explain. So as it is the first time, I will teach you how to do the online exam. So I'll give you a demonstration how to do the online exam. So once you complete the online exam, you should be able to see your marks. You can find the correct answers and wrong answers. And also you can download the paper as well. So the paper is downloadable after doing the exam. So every time before the exams or free papers or maybe a mock paper series, mock exam paper series, I'm going to upload. I already uploaded the papers. Papers are available. I will make you to available just before the exams class. You have to do the exam. Once you submit, you should be able to download the paper. So before the class, you just do the exam, download the paper, get print out, come to the class. I'll explain you regarding the marks. So regarding your answers. So now I'm going to explain you how to do the exams here. Okay, perfect. So just log into More Education, please. So everybody have to follow with me because I'm going to tell you how to do the exam now. Then only you can get the answer. Right? Please log into www.moureducation.com. So once you log in, you have to sign in. Okay, perfect. Go to More Education. So you need to log in. Here, if already you have a login ID, you can go to the login ID with your email and password. If you don't have the login ID, there are two options. As if you are a very new student, you never attend to my class, then you can register, create an account. But if you are my student, so then your email address will be the username and password is capital OGR dash your number. If you have any issues with login, you can contact me or my coordinator. Once you logged in, you will see the home page. Once you see the home page, here you can see my papers. No, not the paper, exams. You can see the exams, okay? Home, course, live exam and the live classes and the exams. There is an option called exams, right? Log in, then go to exams. Once you go to the exams, here you can see the exams which are available as you paid. So here there is one exam for the pre-paper discussion. These are for practice exam series. So you can see another free paper discussion which has been uploaded in 2022 June 6th. This is the today's discussion one. So back to home. So I'm again telling, go to exam, go to the specific exam paper here, click that. Once you click, oh my God, sorry. Once you click over the icon, you can see start exam. Here it's showing duration 60 minutes, pass marks 45. You have 3 attempts, but I haven't do any exams here, so it's 0 attempt. But if you do once, then it will show 1 of 3. So you can see your marks, then study, do the paper again later. Then you can compare with your first attempt and second attempt, how about your marks, whether it's increased or not. So give me one sec.
University. WhatsApp audio.
Right. So here for this paper, I have set 3 attempts. So when you join to the mock paper series, definitely I'll give first attempt, then second attempt. So students who are weak, after the special coaching, I'll do additional 1 or 2 attempt. So then you can practice more and more as an exam. So then you will be able to pass the exam. So here, so the exam need to be start. Yeah. So then it will ask some security things. Sorry, right. Okay. You can do the exams through your phone or maybe through your laptops, whatever. So once you select, now you can see the time countdown. It's 59 minutes, 52 minutes, like it's come down. So you can see total questions and your time duration. Within 16 minutes, you need to answer this question. So read the question, do the answering, and finally you need to submit it. Once you submit, you will get the marks. If you fail to finish the paper within that particular time, it might take it might upload spontaneously and you will get the marks. So it's like your exam, final exam. So you can practice your knowledge. You can practice how to do the exams within that time. You can compare your marks with different attempts. So it has a lot of advantage, right? So these are single best. So when you go down, so these are second question number 2, single best, question number 3, single best, question number 4, single best, question number 5, single best. Like when you go down, so after question, so here I put 10 single best and 10 true or false. Oh, I'm sorry, I'll send the paper here. When we put the paper, my coordinator has put true or false in a wrong manner. I will change it. So here the next one is true or false. I will show you with another exam. Here for the practice exam 1. So first attempt I have done, my marks. You can go to the view marks. Here you can see what are the answers, what are the correct answers, what are the wrong answers. Okay, back home. Start exam. Even you can print the paper here. See, it's coming. True or false will be appearing like this. Commonly presented with palm and soul, true, false. You can mark either true or false. So regarding obstetric cholestasis, so you can mark true or false here. Here, this is true or false. That is SPA. Right. So once you done the paper, submit the answers, submit the test. So then you will get the marks. Confirm. Yes, I have submitted. So I did 2 attempts out of 3. First attempt I got 5 marks. Second attempt I got 0 marks. You can see your answers. You can compare with your 2 attempts. So if you want to print the paper, print the exam. So the print exam option will be available once you finish the paper. So invariably you have to do the exam, then only you can take the paper, you can print out, you can study further. I'll do the question explanations here after doing the exam. So are you all clear? So I'm explaining you. Go to the More Education, log into More Education, go to exam, go to the particular exams, then you can do start exam. Once you finish, you can print the exam. After submitting the paper, you can see your marks, you can see your answers as well. So this is the answer you have given, that is true. This is the answer you have given true, but it's the answer is wrong, because the correct answer is this. Below you will get the answer scheme as well. So you are getting your marking scheme, you are getting your correct answers, you're getting the marks, and you are getting you might be easily compare your answers with atoms, right? So I think you all have to do the practice here. So even my the practice exam series is going to be like this. I'm going to do all the practice exam or mock exam series through the More Education platform. So that's why I have deactivated the exams now. Once I start the exams, say for example, if the class is going to start today, Saturday 12:30, Friday 12:30, I will activate the exam. So you all can do your exams within that 2.5 hours time. Submit the paper, know your marks. No one can see your marks, only you can see the marks except me. And you can get the printout, take your printout and keep with you. I'll do the class. That will be a live class. Then we will do each and every question, and I will explain you the answers. Then after finishing the class, I will upload those videos into the More Education platform. So anytime you can just go through and watch those videos again and again. Then I will let you to do the second attempt. So that time you can do the particular paper again. You can compare with the previous marks and the second attempt marks. You can see whether you improved, whether you know the stuff. If you are still doubt about some answers and things, my class video will be there in the course. Then you can go and watch the video. You can clear your doubt. Even if you have further doubt, you can contact me, or you can send a text me, or you can send a message through the platform in that particular exams column. You can, so I'll show you that too. So you can send a questions or doubt through that. Yeah, I'll show you how to do that. Say for example, if it is obs and gynae free paper, Yeah, free paper discussion. Here, once you go here, you can see there is an option called discussion. Go to the discussion, select the paper one, select the subsection here, April. So whatever, then you can write your doubts. You can type your doubt. You can upload the audio file. You can upload an image or video files, whatever, and just send it to me through the platform. So I will answer through the platform as well. You don't need to know my contact detail, anything. When you ask the question specifically, so I will know which question you are asking about. So which paper you are asking about. So in that particular course, in paper number 1, you have a doubt, you can type and send it to me. Whenever you do questions, whenever you have doubt, you can contact me through this platform. Okay. So this is how we are going to do our mock exam series. So that is what it's mock exam. So you are going to do your exams like your final exam. So when you go to the hospital or when you go to the exams, that final exam should not be like an exam. That should be like your one of the mock exam series class, because when you do 10 papers with me like that, just before the exam, if you do 10 times like an exam, you won't feel as a different one in your final exam, because that will be the 11th class, like your 11th class. So we'll do practice like that. So that is one of the reason now we are having still, even last time, overall pass rate is 45%, but my students pass more than 95%. It's I'm not telling the random numbers. You can ask your seniors. The pass rate is very high among my attended students, because they know the correct way. They know how to answer the question, how to approach the question. Okay, now I'm going to send you the paper through the WhatsApp groups. So you all can see the paper as this is the first class. I just want to make you to do the exam. So now I'm sending the paper. So I'm sending now. So you all can go through the paper now. Then, yeah, of course, we'll start the discussion after that. So give me 1 sec. In 2 minutes, I'll send through all the groups. Then we'll start the paper. If you have any question while I am forwarding this paper, you can ask from me regarding approaching to the Maura or doing the exams through the Maura. So if you have any issues, you can ask me or raise a question. I can help you. Even when you do the exams later, if you have any questions, please feel free to contact me or my coordinator. They will help you to overcome. But please try to do these exams through the platform, because that is the only way will make you to pass the exam easily. Hope you can understand what I'm telling, because these are just our experience, what we have done in past and what we have achieved, right? So because in ERPM story, everybody knows the pass rate of obs and gynae is like 30%, but now you can see how many students are passing. So today I'm with my phone, I'm very busy, because most of my students now got through the exam and they are sending message, I got through and this is what. So I'll share a few of the students response and all to you, so then you might understand how the seniors felt about the classes and the platform and hospital appointments and what they have learned during the hospital appointments and all. So definitely you also have to do that things. Okay, so I have done the sharing business. So shall we do the paper? So now you all can, have you all find the paper? Do I want to send through this Zoom meeting as well? Yeah. Okay. Everyone in the meeting file. Computer, yes. Here we go. Perfect. Right. Done. So you can find the paper in Zoom set as well. So now you can find the paper. So thereafter, I won't send the paper. As I told you, you all have to do the exams through the Maura. I'll upload this video. It will help you to do the exams in the Maura. So Anjana, hi. So you all have to do the exams through the Maura. Then you can, of course, you can download the papers. Then we'll discuss. Perfect. Shall we start the paper? First, we'll start SPA. Then we'll do the MCQ. Question number 1. In counseling women regarding the risk of vaginal delivery on the background of one previous cesarean section, which one of the following would not be generally be considered as an absolute contraindication to VBAC attempt? Yeah, any answers? So this should be a discussion. Please, I'm expecting your answers. Ashok, what is the answer?
So, previous uterine rupture.
Okay, so maybe we'll see. First, always I'm telling a same fact. Don't try to memorize the answers. Please try to understand the fact what I'm teaching. You got the point? So first read the question, gather information, identify the relevant information or facts, use your background knowledge, think rationally, answer your question. These are the steps always you need to follow to pass the exam, right? This is what you need to do it in your exam. So here I'm reading the question again. Please carefully read the question. In counseling women regarding the risk of vaginal delivery on background of previous cesarean section. So a woman with previous cesarean section, which one of the following would not be generally considered as absolute contraindication for VBAC? So in the other word, what they're asking is, what are the contraindication for the VBAC? A woman with past section wanted to go for a vaginal delivery. So what are the absolute contraindication? Right, lower lying placenta at term. So what is VBAC? Vaginal birth after cesarean section. So when you try for a vaginal delivery, there should not be any contraindication for vaginal delivery, right? So whether it's previous section or not previous section, doesn't matter. If you can't go for a vaginal delivery, then you can't try. So if it is a placenta previa, it means the placenta is in the lower segment and which is covering. So they have mentioned lower lying placenta at term. So in term, the placenta is in the lower part. If it is a placenta previa, can you go for a vaginal delivery? Is it possible to go for a vaginal delivery? So obviously no. So all the contraindication for vaginal delivery, it's contraindicated for VBAC as well. Are you agree that if you can't go for vaginal delivery, obviously you can't go for vaginal delivery. So obviously placenta previa is contraindication. So yeah. So they're asking would not be considered as absolute contraindication. So placenta previa is considered as absolute contraindication. So that is not the answer. Previous uterine rupture. What do you think? A woman with previous uterine rupture, is it possible to go for vaginal delivery next time? Anybody, please. If you don't answer, then I also might fall asleep. If a woman had a uterine rupture, is it okay to go for a VBAC next time? No, you can't, because a woman with previous uterine rupture carry risk for the uterine rupture in consequent pregnancy by 5%. If it is a previous cesarean section going for a vaginal delivery, risk of uterine rupture is 0.5%, 1 in 200. But if she had a history of uterine rupture in previous pregnancy, the risk will increase by 10-fold when compared to without rupture. So the risk will be 5%. So when you go for a vaginal delivery this time, she will have risk of uterine rupture around 5%. So we don't allow her to go for a vaginal delivery because which has high risk to have a uterine rupture. So it's an absolute contraindication. True. Twin pregnancy. Past section with twin pregnancy. Can she go for a vaginal delivery? Or can't she? What do you think, Anjana?
She can go for vaginal delivery.
Yeah, of course, she can. There is no contraindication. Even though it's past section, it's twin pregnancy, each baby is a small, yeah, you can go for a vaginal delivery. There is no contraindication. So this is not a contraindication. So obviously this answer would be the suitable answer. Previous T-shape incision. What do you understand by T-shape? Usually we put a transverse lower segments incision. Sometimes if we feel difficult to deliver the baby, to extend the opening, we just make a incision towards fundus longitudinally like a inverted T to extend the opening. That is called T incision. So if it is a T incision, obviously the risk of uterine rupture will increase by like 1.8%. If it is a transverse lower segment cesarean section, uterine rupture is 0.5%. But if it is a T or J, other than the transverse lower segment, the risk of uterine rupture is a bit higher. So previous T incision will carry more risk of uterine rupture. But keep it in your mind, sometimes when we do questions, this is one of the past paper. When you read the guideline, previous T-shaped incision, it's not an absolute contraindication. It's a relative contraindication. Right? Obviously, placenta previa, absolute contraindication. Previous uterine rupture, absolute contraindication. Lower segment fibroid, absolute contraindication. Right? Transverse line labor, absolute contraindication. But previous T incision or J incision, it's not an absolute, it's a relative one. And previous classical cesarean section, it's an absolute. Classical means not a lower segment transverse, it's a vertical incision. In vertical incision, the problem is you are cutting a lot of muscle fibers, not the lower segment. Lower segment has less fibers. So as it is less muscle fibers in consequent pregnancy, risk of rupture is less. But When you do the longitudinal cut, you are cutting more fibers towards fundus. So next time when the uterus try to contract, those muscle fibers can easily detach and rupture risk is a bit high. That's why classical cesarean section is risk for the uterine rupture. So we don't go for a vaginal delivery. So it's a absolute contraindication. So here you have 3 absolute and 1 relative and 1 you can go for a vaginal delivery. So this is single best answer. You have to select one answer. So among these, which one is best answer? Obviously twin, because twin there is no restriction. Rest of the things you have restrictions. Some are absolute restrictions, some are relative restrictions. So among these, the twin pregnancy will be the most suitable answer. Do you have any question? So answer C. Do you have any questions? No, perfect. Question number 2, a 45-year-old mother of 5 presented with menorrhagia, dysmenorrhea, on examination, tender, symmetrically enlarged uterus, palpable with 10 weeks gravit size uterus. What is the mostly likely diagnosis? Yeah? What is the most likely diagnosis? Saranija, what is the mostly likely diagnosis?
Adenomyosis.
Okay, why? Why we are thinking as an adenomyosis? So, yeah, I agree with you. The answer is adenomyosis, of course. So my question is, why it is adenomyosis? What is the reason for the adenomyosis?
Multiparous symmetrically enlarged.
Fantastic, fantastic. Thank you so much. Yeah. So always, as I told you, when you read the question, you have to gather information. So in this question, what are the most important keywords which lead you to identify the answer? The first keyword is 45 years. She is in her 40s and 50s, right? 45 years. Mother of 5, it means she's multiparous. So 45-year multiparous with menorrhagia and dysmenorrhea. It means heavy bleeding and painful bleeding. On examination, uterus is symmetrical. So if it is a uterine fibroid, even it can common in 45. But there are features against for uterine fibroid. One, uterine fibroids are asymmetrical enlargement, because you can have fibroid in the right side, you can fibroid in the left side, you can fibroid in the fundus. So asymmetrical enlargement. But if it is an adenomyosis, what is adenomyosis? Presence of endometrium into the myometrium. So here the myometrium is going to enlarge. So as the whole myometrium is enlarging, the enlargement will be symmetrical. Got the point? The enlargement is going to be symmetrical. So symmetrical myometrial enlargement. Symmetrical myometrial enlargement. Okay? Then in fibroid, yes, of course, you might get heavy bleeding. Same time, in fibroid, you will not have painful bleeding. It's usually painless bleeding. But adenomyosis will have painful bleeding. So painful heavy bleeding, it's leading towards adenomyosis rather than fibroid. So uterus is enlarged, painful, heavy bleeding, so it's most likely to be adenomyosis. And also, multiparity is a risk factor for adenomyosis, because as we all know, when the uterus is enlarging or distending during the pregnancy, endomyometrial junction. Let me to explain, please. So this is your uterus. This is your endometrium. Here, the endometrium and the myometrium has a demarcation that is called endomyometrial junction. So when the uterus get distended, this junction will get weaker. Because of the weakening of this endomyometrial junction, this endometrium might invade into the myometrium. So endometrium might invade into the myometrium, started to proliferate and bleed and cause bleeding and pain during the menstrual cycle. That's called adenomyosis. So fibroids are common in primates and adenomyosis are common in multiples. So here most of the symptoms or risk factors which is suggestive of adenomyosis, because she's 45, multipara, and menorrhagia and dysmenorrhea, symmetrically enlarged uterus, almost 10 weeks size. So mostly diagnosis adenomyosis. Perfect. Answer A. Question number 3. A 16-year-old girl with primary amenorrhea. Her height is 5 feet. She has no secondary sexual characteristics. Examination revealed the presence of uterus and vagina. She has a high FSH and LH level with low estrogen level. Karyotype XY. XY means it's male. What is the most appropriate diagnosis? Yeah, anyone please? What could be the most appropriate diagnosis? Yeah? What could be the most appropriate diagnosis? I don't know how many of you can come to the answer for this question. Anyhow, I'll explain you. Anyone, please? One answer came as Turner's. Anyone? A, absence Mullerian inhibition. Right, okay. Nimashi, what could be the answer for this? Testicular feminization. Okay. E, Turner's. I'm really sorry, those who are answering as Turner's. Turner's syndrome is female, right? It should be X node. Karyotyping, how can you say XY? It should be X node. So they have mentioned karyotype is XY. It means it's a male karyotype. Yeah, Hasaroki, it is a Swyer syndrome, may be correct, because it's the Swyer syndrome is almost like a male Turner's. But among these, what could be the answer? So let me to explain this question. So how to break this question? Okay. 16-year-old girl with primary amenorrhea. So she's 16 years, primary amenorrhea. Her height is 5 feet. So 5 feet means quite okay, right? So there is no height reduction. Anyhow, its height is 5 feet. So her height is okay. She has no secondary sexual characteristics. So if you see this word, she doesn't have secondary sexual characteristic, means what you understand from that word? What you understand from that word? What is secondary sexual characteristics? Like for a female, breast development. feminization features. For the male, masculinization. The hair grow in the face, voice change. So all these secondary sexual characteristics, either male or female, it's due to sex hormones, either estrogen and progesterone. Agree that it's due to sex hormone. Here there is a problem with secondary sexual characteristics. So what does it mean is there is a problem with sex hormone. There is a problem with gonads. The gonads are not producing adequate sex hormone, either testosterone or estrogen. So the first information I gathered from this word is no secondary sexual characteristic means there is no sex hormones. Examination revealed presence of uterus and vagina. So she has uterus, she has vagina, but her karyotyping is XY. So genotypically, according to the gene, that particular person is male. But phenotypically, appearance-wise, that is female. She is having uterus, she is having vagina, but she does not have gonads. It means she has some problem with the gonads. Gonadal dysfunction, same time, female phenotypical appearance and genotypically it's male. When you see the FSH and LH, it's high. So hypothalamus and pituitary, it's functioning well, but the gonad is not responding. This condition is called as hypergonadotrophic hypogonadism. Your tropic hormones, FSH, LH, the stimulating hormones are in excessive amount due to malresponse of gonads. So the tropic hormones activity is a bit high, gonadal activity is low. So the second evidence saying her gonad is not functioning. So that's why her tropic hormones are high, but gonad is not functioning. So as we all know, during the age of puberty, hypothalamus will secrete GnRH, that will stimulate pituitary to secrete FSH-LH. That FSH-LH will stimulate the ovary, then ovary will release estrogen or testosterone, that will cause secondary sexual characteristic. So here, hypothalamo-pituitary activity is there, but the ovary is not responding. That's why she is not attaining menarche. That's why she is not having secondary sexual characteristic. So obviously we know there is a problem in the gonads. So gonad is not responding. So what could be the reason? Could be a gonadal angiogenesis. Could be Turner's. Could be Swyer syndrome. Yeah, because gonad is not responding. So what could be the answer here? How you can explain, even though she is XY, why she is having uterus and the vagina? You might have doubt. Yeah, of course, because when there is an absence of gonads, when there is no gonads, during the organogenesis, during the first 12 weeks of intrauterine life, organogenesis. Initially, gonadal ridge will form. From the gonadal ridge, either ovary or testis will form. If it is XX chromosome, ovary will form. XY chromosome, testis will form. If XY, when the testis form, testis will secrete two types of hormones. One is testosterone. Second one is Mullerian inhibiting substance. What is the function of testosterone? Testosterone will stimulate the Wolffian duct to produce internal male organ. What is the function of Mullerian inhibiting substance? That will suppress the Mullerian duct, because Mullerian duct is the one give rise the female internal genital organ like uterus, ovary, tube, upper part of vagina. So that is how the male will form, because MIS will suppress the female organ and enhance the Wolffian duct, male organ. So male internal genital organ will form. Same time, this testosterone will stimulate this urogenital sinus develop into male external genital organ. Like penis, scrotum, those will develop under influence of testosterone. So in case, if it is a XY, what will happen? Gonadal ridge will develop as the ovary. So there is no testosterone, no MIS. So without testosterone, Wolffian duct will not develop. Without testosterone, urogenital sinus will not develop as penis, will not develop as scrotum. So there won't be any male external genital organ. There won't be any internal male genital organ. Same time, there is no MIS. So in the absence of MIS, what will happen? Female internal organ will develop from the Mullerian duct. So Mullerian duct will develop as uterus and the vagina. And in the absence of testosterone, urogenital sinus outside will develop as female. So ultimately, female internal and external genital organ will develop. This is how the development of female genital organ will occur. In gonadal agenesis, what is happening, even though it's XY or XX, never mind, here there is a problem with the gonadal ridge. So here there is no gonads, no testosterone, no estrogen, neither develop. Neither testis, no ovary. Nothing develop. So there is nothing. So without any gonads, there is no testosterone, no MIS. In the absence of testosterone, in the absence of MIS, that person will develop as female. So here the internal and external genital organ will be like a female, but without gonads, during the puberty, that person can't develop or produce testosterone or estrogen. So it's going to be absence of secondary sexual characteristics. So answer is gonadal agenesis. Question number 4. A 26-year-old woman presented to the gynecology ward with fever for 2 days. Fever for 2 days. Bilateral lower abdominal pain and dysuria. She had her last menstrual period 2 weeks back. On examination, she was found to have a temperature of 38, abdominal pain, pelvic examination, revealed tenderness over the suprapubic region with cervical motion tenderness. She also gave a history of casual unprotected sexual intercourse 4 days back. What is the most likely diagnosis in this woman? Yeah, what is the most likely diagnosis? What is the most likely diagnosis? What is the most likely diagnosis? Yeah, what is the answer? C, D, C, what is C? Trichomonas vaginalis infection. Okay, UTI, urinary tract infection. Right, okay, thank you for your answers. Right, I'm reading the question again. Please carefully concentrate the question. 26-year-old, so she's quite young, had a fever with bilateral lower abdominal pain and dysuria. So she's having pelvic pain and dysuria. She had a period 2 weeks back and tenderness over the suprapubic region with cervical motion tenderness. So it's mean obviously she's having kind of pelvic infection and also dysuria as well. Because low abdominal pain and dysuria. Could it be a UTI? Yeah, of course. Because in UTI, cystitis also, they will have temperature. They will have low abdominal pain. They will have dysuria. So these symptoms suggestive of UTI. I agree, totally agree. But how can you explain cervical motion tenderness in UTI? Cervical motion tenderness, which is suggestive of pelvic infection. So UTI, you won't get cervical motion tenderness because in UTI, the infection is in the urinary tract, not in the genital tract. Here, she is having infection in the urinary tract as well as genital tract because she is having low abdominal pain and the dysuria and also low abdominal pain and cervical motion tenderness. And also, she gave a history of unprotected sexual intercourse 4 days back. She had unprotected sexual intercourse 4 days back. 2 days later, she developed cervical motion tenderness, low abdominal pain, dysuria, and fever. What could be the infection? What could be the infection? Anyone, please?
Trichomonas vaginalis because related.
More than Trichomonas vaginalis because they're
Bacterial
parasitic.
cirrhosis.
It's a parasitic infection. Very good, Charit. Either it could be a chlamydia or Neisseria. Very good, Hazrul. Because it's sexually transmitted infection which can cause pelvic inflammatory disease as well as urethritis. Right? This chlamydia and Neisseria can cause urethritis as well because which will infect only columnar epithelium. The columnar epithelium will found in the urethra. So urethritis is very common. More than 50% of the time, chlamydia and Neisseria will cause urethritis. So pelvic inflammatory disease associated with UTI is quite common with chlamydia and Neisseria. So this history is mostly suggestive of acute PID due to either Neisseria or chlamydia. Because following sexual intercourse, he developed low abdominal pain, cervical motion tenderness, and dysuria and fever. So it should be a acute pelvic inflammatory disease. Got it? Perfect. So answer D. Right. Question number 2. Yeah, congratulations. Very good, Samsung. Samsung also answered very nice. Nowadays, Samsung also do the exams, ERPM exam. Yeah, perfect. A primipara is in premature labor at 34 weeks. During second stage, the fetal heart rate drops to 100 beats per minute. CTG shows type 2 deceleration. Head is 2 centimeters below the ischial spine. direct occipito-anterior position, the adequate pelvis. What is the best management? Yeah, what is the best management? What is the best management? Answer, please. B, C, D. Yeah, any answers, please? Yes, Halima, what is the answer? B, cesarean section. Okay, right. We'll read the question again. A primary mother, premature labor, 34 weeks. Second stage, heartbeat dropped. So it means fetal distress in second stage. Already cervix dilated to fully. You are waiting for the spontaneous delivery. While you are waiting, the baby developed bradycardia with type 2 deceleration. So in second stage, if it is a fetal distress, your aim is to expedite the delivery. That is your aim, simple as expedite the delivery. You can't wait for the spontaneous delivery. So what you want to do, you want to take the baby out. You have to be a bit hurried to deliver the baby, that's it. Expedite the delivery. So how can you expedite the delivery? Either you can do instrumental delivery or you have to go for a cesarean section. Whatever the means, you need to take the baby out, that's it. So either you have to go for an instrumental delivery or cesarean section. So if you want to go for an instrumental deliveries, then you have to select whether she is having any contraindication for instrumental delivery and which instrument is suitable for her. So the first is fully dilatation, so you can go for an instrumental delivery. This is 34 weeks, it's preterm. So as it is preterm 34 weeks, obviously vacuum delivery is contraindicated because which can cause intracranial hemorrhage. So vacuum delivery is a contraindicated before 34 weeks. Caution or relative contraindication in between 34 to 36. After 36 weeks, you can go for a vacuum delivery. So here the vacuum is not an option. Then the second instrument is forceps. Is it okay to go for a forceps? So first of all, you need to assess what type of forceps you need to, what type of instrumental delivery you need to do. So you can classify the instrumental delivery into high cavity, mid cavity, low cavity, and outlet. So if it is outlet means head should visible without separating the labia. If it is low cavity means below +2 centimeter from the ischial spine, but it's still in the vagina. That is low cavity. Mid cavity means above 2 centimeter, but below the ischial spine level. It means station 0 to +2. Below +2, it's low cavity. If you can see the baby's head, that is outlet. If it is above ischial spine, that is high cavity. So if it is a high cavity, it's contraindicated for instrumental delivery. You can't go for an instrumental delivery. So either it should be a mid cavity or low cavity or outlet. If it is an outlet, you have to go for a Rickley forceps. If it is a mid cavity or low cavity, you have to go for Neville band or Simpson's or Keelant. Keelant is for occipito-transverse position. If it is an occipito-anterior or occipito-posterior, you can go for either Simpson's or Neville band. So in this scenario, what cavity this is? Head is 2 centimeter below the ischial spine. So this is low cavity. So low cavity and it's occipito-anterior position. So you don't need to go for a Keyland. You don't need to turn it because for the Keyland, it should be occipital transverse. It's an occipital anterior. So baby is in low cavity, occipital anterior position, 34 weeks, fully dilatation. There is no contraindication for the mid cavity or low cavity forceps. So the easiest way for this baby is low cavity forceps delivery. No need to go for cesarean section. There is no indication. So obviously we have to expedite the delivery by instrument delivery. So the first answer is gone. No need of cesarean section. Second answer is gone. Neville band. Yeah, of course, that is low cavity forceps. That would be the answer. Vacuum, contraindication, Rickley, that is for the outlet, not for the low cavity or mid cavity. So if you properly assess the question, you will get only one answer. If you don't understand the question, you will be confused. Okay, perfect. So answer C. Question number 6. A 35-year-old lady consult you for a contraceptive advice 2 months after the delivery of second child. She breastfeeding, her BMI 35. She has had treated for vascular thromboembolism after the delivery of her first child. What is the next step of management? Okay, so she came for the contraceptive advice. So always when you counsel a mother for contraception, always you have to consider some criteria. Can anybody know what is that criteria? Anybody, please? Are we using any criteria to select the suitable contraception? Yes, please. Very good, Hasruk. Very good. MEC criteria, medical eligibility criteria, MEZ. So, medical eligibility criteria. So, what is this medical eligibility criteria? This criteria has 4. One is no restriction. MEC 2 means there are restrictions, but benefit outweigh the risk. MEC 3, risk outweigh the benefit. MEC 4, it's absolutely contraindication for the lady. So always you have to think whether it's contraindicated or relative contraindication, or whether she has some kind of complication, but the benefits is more than the complications. And the MEC 1 is there is no limitation. You can use freely. So this medical eligibility criteria is individualized. Say, for example, one patient might come to you. For her, condom could be medical eligibility criteria 1. There is no restriction for the condom. You can use condom because it is non-hormonal, side effects are less, so you can choose condom. But another lady came to you for the contraceptive advice. For her, condom could be medical eligibility criteria 4 if she has latex allergy. If she has latex allergy, then using condom might cause anaphylaxis and she might die. So this medical eligibility criteria is individualized. So whenever you prescribe or counsel contraception, always you have to look for the medical eligibility criteria. That is 1. Second, you need to look for the efficacy of the contraception, successfulness. So even though the condom is no restriction or less side effect when compared to other method, the failure rate is very high. All right. So always you have to think about the efficacies. So how to assess the efficacy is failure, by the failure. So we just assess how many failure with using a particular method. So when the failure is a bit high, then we can say the efficacy is less. That is second. Right. Third one, there are the features like eligibility or availability, effectiveness, number of kids, right? So there are so many factors when you counsel. Here, this lady is BMI 35 and she's breastfeeding, had a history of thromboembolism. So mother who had a thromboembolism and breastfeeding, always estrogen containing contraception are contraindicated because which can provoke another thromboembolism and estrogen will suppress the breastfeeding. Mother who is doing breastfeeding or who is in breastfeeding, COCP is contraindicated for 6 months duration. So here the obesity, previous thromboembolism, breastfeeding, considering all these factors, prescribing hormonal contraception will not be a good option for her. That is not a good medical eligibility criteria for her. So always you have to think about non-hormonal method. And it should be a LARC method. What do you understand by LARC method? What do you understand by LARC method? What is LARC? Have you heard LARC? Just go to my theory class, please watch that contraception lectures, please. Yes, LARC means long-acting reversible contraception. Long-acting reversible contraception. So if you put that contraceptive device or if you apply a contraceptive method, the action lasts for a long period. So what is that long period is? The administration of the contraception should be less than a month frequency. Should be less than a month frequency. Say, if it is an OCP, you have to take contraceptive pills every day. So more than once in a month. So it can't be a LARC. If it is an IUCD, once you put, you have to change it after 10 years. So it's less than a one time in a month. So in LARC, the advantage, patient will not forget to take the contraception. If it is an OCP, she might forget one tablet and she might become pregnant. Failure rate is a bit high. If it is a condom, she might forget to put a condom. So the LARC method with 2 babies will be the best option. So considering these factors, for her, the best option is insertion of copper IUCD, which can last for 10 years. The efficacy is 1 in 1,000 failure, non-hormonal. Yeah. So it is good for the obesity as well. Yeah. So then best answer is insert copper IUCD B. Question number 7. A 14-year-old girl presented with an odorless whitish discharge for 2 months, no pain, no burning, no itching. She attained menarche 6 months ago. What should be the best management? Candida, so clotrimazole cream. Okay. Any other answers? Any other answers? B, clotrimazole. C, okay. Okay. So here she's 14 years, odorless vaginal discharge. Actually, she's having vaginal discharge, of course. But the discharge is odorless, no pain, no burning, no itching. So this discharge is most likely to be a physiological discharge. And especially, she attained menarche 6 months ago. Her reproductive system exposed to estrogen recently. When it is exposed to estrogen, what will happen? the estrogen and progesterone secretion will increase. Yeah, the physiological one. But if it is a candida, then curd-like itchy discharge. If it is a PID, gonorrhea, malodorant, jello discharge. If it is a bacterial vaginosis, Fissure de Grace discharge. So here it's colorless, odorless, no pain, no itching, no burning. It's physiological discharge. So patient might present to you because she recently experienced this one. So that's the reason. So just reassure, saying it's physiological. The answer, C. Question number 8. A 60-year-old woman came with a report of cervical smear which shows atypical squamous cellular pattern. What is the next step of management? What is the next step of management? D, hysterectomy, cervical punch biopsy. Nimashi say cervical cone biopsy. Somebody say colposcopy. Somebody say blood for HPV antigen. Okay, great. So 60-year-old woman came with cervical smear report. What is this cervical smear? What is this cervical smear? What is this cervical smear? How do you call this test? You know, I'm getting so many messages after today's results. What is cervical smear? How do you call this smear? Cervical smear is a screening test. Cancer screening test. So what do you understand by screening test? Screening test means you are just doing the test for each and every one to identify the high-risk person. So you should be able to understand the difference between screening test and the diagnostic test. So the screening test will not be a diagnostic. With the screening test, you can't say this is a disease. You can identify the risky mothers who are having risk of having disease. So cervical smear is a screening test. So it means it's showing she has high risk to develop, or she's having high risk to have abnormal cervical pathology. Could be a pre-malignant disease, could be a malignant disease, I don't know. But the screening is positive. But if the screening is negative, then you can let them go home. You can discharge them from the follow-up. Because even the first screening test, she's negative. But screening test positive, you can't do any intervention depend on the screening test. You have to go for a diagnostic test. If the screening positive, what is the next diagnostic test to identify whether she is having abnormal cervical pathology? Yeah, colposcopy and biopsy. You have to see the cervix with the help of colposcopy and identify the abnormal area. If you can identify an abnormal area only, you have to take a biopsy. If colposcopy is normal, then it's normal. Because screening test might have false positive results. Okay, so as she presents with cervical smear test with abnormality, we are not going to do any intervention. We are not going to do hysterectomy or any kind of things. We just do a colposcopic diagnostic test. Answer A. Question number 9. A primary gravida is admitted with a history of sudden onset of abdominal pain and moderately severe bleeding at 34 weeks. She is pale, blood pressure 80/60, pulse rate 110, abdomen very tender on palpation. There are no uterine contraction, fetal heart rate is 130, fetus is in cephalic presentation, the head is engaged. What is the most appropriate treatment? What is the answer? What is the most appropriate treatment? What is the answer? Yeah, what is the answer? C, D, B, right, okay. So, okay, just tell me what is the diagnosis, this one? What is the diagnosis?
Placental abruption.
Very good. It's a placental abruption. Thank you so much. So it's a placental abruption because symptom, antepartum hemorrhage. She came with vaginal bleeding, abdominal pain, tender abdomen. So this is antepartum hemorrhage due to placental abruption. Antepartum hemorrhage due to placental abruption. So if it is an antepartum hemorrhage, now the placenta has separated. Once the placenta separate, it will reduce the bleeding, or it will reduce the blood supply to the baby. So baby is in danger. Once the placenta separate, mother is going to bleed inside the uterus, and the placental substance will enter into the maternal circulation, which can cause disseminated intravascular coagulation. So ultimately, it will be a risk to the mother as well. So placental abruption can cause dangers to the baby and mother. So the management of placental abruption depend on the severity of the complication to either mother or baby. Always when you consider the management option, to whom you will give a priority? To whom you will give priority? Of course, mother. Always you have to give priority to the mother, not for the baby. If mother is stable, then priority to the baby. If both are stable, then you can plan, depend on that. So here, when she comes with placental abruption, her blood pressure is 80/60 and pulse rate is 110. So what do you understand by this?
Hypovolemic shock.
Very good. It's hypovolemic shock. So its mother is compromised. When the mother is compromised, you have to give priority to the mother. Are you going to wait for the dexamethasone for baby's benefits? Are you going to wait for the spontaneous delivery for the baby's benefit? No. Here, you need to deliver this placenta and the baby as early as possible to save the mother. So always you have to give priority to the mother. So baby has to deliver immediately by cesarean section. That will be the most appropriate treatment. What could be the next step of management? You have to preserve 6 pints of blood, give IV fluid, blood transfusion, stabilize the patient, do cesarean section, and deliver the baby. That would be the next step. But here, the most appropriate treatment will be delivery, and mode of delivery should be cesarean section. So answer C. Question number 10. A 25-year-old primey with twin pregnancy, it's transferred to the labor ward. She had delivered the first twin without any complication 1 hour ago. Abdominal examination revealed second twin in transverse lie, lico content is reduced, and there are uterine contraction. On vaginal examination, cervix is fully dilated and membrane absent. Fetal heart rate 140. What is the most appropriate management? What is the most appropriate management? Yeah? What is the most appropriate management?
External cephalic version. Second twin in transverse lie.
Right. So if it is a twin delivery, after first twin delivery, if the second baby is transverse lie or obliquely or breech presentation. Either you can do ECV, external cephalic version, and deliver as cephalic, or either you can do internal podalic version and breech extraction. You can put your hand inside, hold the baby's leg, and pull the baby's leg towards down and pull the baby out. That is called breech extraction. But to do ECV or internal podalic version, you need LICO. Without LICO, if you pull the baby, then it might cause fetal damage. Now, this baby delivered, the first baby delivered 1 hour ago. It's too late. After 1 hour, even the baby is in transverse lie and membrane got rupture, LICO trained completely. There is minimal LICO, uterus is contracting. With this contraction and reduced LICO and prolonged labor, is it possible to put your hands inside and pull the baby out? Is it possible? No, which can further damage the baby. So cesarean section immediately would be the answer. So answer C. Right, we will move to the MCQs. So regarding endometriosis, what is endometriosis? Presence of endometrium outside the endometrial cavity is endometriosis. So this usually common maybe after 20 to 30. Yeah, after 20 only it's common. When it is outside, which can cause pain, fibrosis, adhesions, bleeding, narrowing of the canal, so which can cause ectopic pregnancy, tubal blockage, subfertility, a lot of complication with endometriosis. So regarding endometriosis occur in women under age of 20 years, it's false. It's usually common after 20s, it's false. Cause female subfertility, true or false?
So chocolate cyst, like, can you
Yeah,
give up?
which can cause female subfertility because there are so many reasons. One is which can cause severe painful intercourse because of adhesions and inflammation, so which can affect the sexual life. Second, which can cause tubal narrowing and tubal blockage, which can cause endometrioma and poor quality ovum, which can cause inflammation in the tubes, inflammation in the ovary, inflammation in the uterus, which can affect the tubal motility, which can affect the implantation. So there are so many reasons for subfertility in endometriotic patients. So that's true. Can cause dyspareunia. Dyspareunia means painful intercourse. Yes, because of inflammation and adhesions. That's true. Spontaneous regression with pregnancy. What do you think? True or false? Spontaneous regression with tubal pregnancy. True or false?
Because
Yeah. Sorry? Yeah, that's true. Spontaneous regression because during the pregnancy, placenta will produce more progesterone. What is the function of progesterone is? Progesterone will suppress the endometrial tissue. That will suppress the endometrial proliferation. Here in this woman, problem is the endometrial tissues which are present in the peritoneal cavity or outside the endometrial cavity started to proliferate and shed off and bleeding, inflammation, fibrosis. So endometrial activity outside the cavity is the problem. So if you can suppress the endometrial activity, then the disease will improve. So what are the ways to suppress the endometrial activity? One is becoming pregnant. There is no endometrial proliferation, no menstrual cycle, so the disease will improve. Post-menopause, disease will improve. Oophorectomy, there is no estrogen, disease will improve. Or you can give progesterone from the outside, either oral progesterone or local progesterone. Those progesterone will suppress the endometrial tissue. Yeah. So endometrial So spontaneously regress with progesterone, yeah, that's true. There may be nodules in the POD. Yeah, because in the pouch of Douglas, there could be endometrial deposits and causing fibrosis, causing nodular lesion. When you do the vaginal examination, you can feel some nodular lesion in the POD. Yeah, that's true. So answer question number 1, false, true, 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 true. Question number 2, which of the following statements are true regarding normal pregnancy? Blood pressure fall in second trimester. Yeah, that's true. What will happen during the pregnancy? Blood pressure start to fall up to T2, mid of the T2 or later T2. Then it started to rise in the later part of the pregnancy. What is the reason for blood pressure drop in pregnancy? Because of the progesterone. Progesterone will relax the smooth muscles. So blood vessels started to dilate due to smooth muscle relaxation effect of progesterone. Due to dilatation of the uterus, blood vessels, the resistance will come down, so blood pressure will come down. So blood pressure drop in second trimester. Yeah, that's true. Actually, blood pressure fall start in first trimester itself. In second trimester also, it will fall. Plasma volume decrease throughout gestration. It's false. During the pregnancy, estrogen level will increase. Estrogen will cause fluid retention. So from the early part of the pregnancy, the plasma volume started to increase. After 28 to 32 weeks, then it will drop, but still it will be higher. So plasma volume decrease throughout gestation, that's false. Increase. There is a reduction in erythrocyte production. It's false. All the protein synthesis, carrier protein, all the anabolic activity will increase during pregnancy. So RBC production also will increase. But even though the RBC increase, the woman will be anemic. That is called physiological anemia due to fluid overload. RBC will increase. Same time, fluid retention will be high. But when compared to RBC and fluid retention level will be higher than the RBC increasement. So ultimately, what will happen?
Plasma dilution.
Hemodilution. So physiological anemia. So RBC reduction, it's false. It will increase. 50% of the women have transient diastolic murmur. Keep it in your mind. All the diastolic murmur during pregnancy, it's pathological. Ejection systolic murmur in pulmonary area during pregnancy could be due to hyperdynamic circulation, which is physiological. But all the diastolic murmurs are pathological. All the diastolic murmurs are pathological.
Pathological.
Yes. So 50% of women have transient diastolic murmur. False. There is an increase in number of polymorpholeukocytes. Yeah, that's true. Because pregnancy is an immunocompromised state. So as the lymphocyte counts reduce as the immunocompromised state, to overcome that immunocompromisation, WBC, especially polymorpholeukocyte count, will increase. Normally in pregnancy, WBC count will be higher. So there is an increase in number of polymorphonuclear leukocytes. That's true. So answer true, false, 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 true. Question number 3 regarding H small, give rise to hyperemesis gravidarum. That's true because in H small, here it's an abnormal pregnancy due to improper fertilization. So as it is an abnormal pregnancy, it's a tropoblastic disease. What do you understand by tropoblastic disease? Tropoblast means placenta. Placental tissue. Here, because of the abnormal trophoblastic cells, these placental tissue cells are proliferating more. These are proliferating more and more. More and more. So these trophoblastic cells proliferate a lot. Got it? Trophoblastic cells are proliferate a lot. So what will happen? The uterus will be larger than the normal pregnancy. Larger than the normal pregnancy. Right? So uterus will be larger than the normal pregnancy. So fundus more than day. These excessive trophoblastic cells produce more HCG. HCG is the one responsible for the vomiting. So this vomiting will be higher due to excessive HCG. Excessive HCG will cause vomiting, hyperemesis. So give rise to hyperemesis, that's true. Excessive trophoblastic cells or placental tissue can cause preeclampsia, early onset of preeclampsia, excessive bleeding. From these abnormal trophoblastic cells, malignant transformation risk is bit high. What is the malignant transformation? Is choriocarcinoma. Risk of choriocarcinoma is bit high. Right? So, treat by suction evacuation. Yeah, of course, because as I told you, these abnormal cells has potential for the malignant transformation. So when you take this abnormal tissue from the uterus, if you damage the uterine wall, these abnormal cells can easily enter into the maternal circulation and can spread to the lungs, brain, and other organ and can cause metastasis. So you should not damage the uterine tissue. Same time, you have to take all the abnormal tissue outside. So that's why what we do, we are using a suction effect, put a suction inside and evacuate all the products. So you won't damage, same time you will suck out all the abnormal tissue. So the treatment which we are doing for the HMOL is suction evacuation. So that's true. Avoid conception for 2 years in follow-up. Now, the follow-up, you don't need to go for a period of 2 years. It should be a 6 month, but this is a bit of different. I will teach you. Right? Right. So a woman with trophoblastic disease, we do suction evacuation. Suction evacuation today. What is the date today? Today is 7th of June. So we have done the suction evacuation for her. This is day 0. Today we have done the suction evacuation. Now, even though you have done the suction evacuation, you don't know whether you have completely sucked out all the abnormal tissue. There could be abnormal residual tissue, there could be recurrence. So you have to make sure entire abnormal trophoblastic tissues has been removed from the uterus before she becomes pregnant next time. Because if she becomes pregnant next time without evacuating completely, these trophoblastic tissues are estrogen dependent. When she becomes pregnant, her estrogen level will goes up. Then what will happen? Under influence of estrogen, those abnormal tissue again started to grow and cause malignancy. That's why before she becomes pregnant, we have to make sure her entire trophoblastic cells has been evacuated out. So how do you know whether evacuated out? You can assess her with tumor marker. What is the tumor marker? I told you trophoblastic cells will produce HCG. So you can follow them with HCG. So today, the day of suction evacuation, HCG is 100K. 1 lakh international unit, 100K. So what you are doing? You are doing another HCG in 2 weeks time. That time it's 10K. So what do you understand by that? Now the HCG count is dropping. So her tropoplastic activity is coming down. In another 2 weeks, it came as 500. It's markedly reduced. Another 2 weeks, it came as 30. In another 2 weeks, it came as 0. So now 0 or 1 or maybe 2, it's negative. So we know after the suction evacuation, 2, 4, 6, 8. Within 8 weeks, the HCG activity became negative. So we are happy. So if the HCG became negative within 8 weeks of time, this is the time duration of 8 weeks from the day of evacuation. From the day of suction evacuation, if the HCG became negative within 8 weeks, she should not become pregnant for 6 months from the day of evacuation. From today, she should not become pregnant for next 6 months if the beta HCG become negative within 8 weeks from the suction evacuation. Sometimes beta HCG might become negative after 8 weeks. Say for example, somewhere after 12 weeks, by 12 weeks only, it became negative. So it means you can't advise her to not to become pregnant for 6 months from the suction evacuation. You have to advise her to not to become pregnant for another 6 months from the day of normalization. From the day of normalization, she should not become pregnant. So this is how the follow-up. I hope you might understand. Here, she should not become pregnant for 6 months since the day of suction evacuation if beta HCG become negative before 8 weeks. If beta HCG become negative after 8 weeks, she should not become for another 6 months since the day of normalization. This is our follow-up, not for 2 years. I will understand what I told. Yes? Any questions? Sachinta? No, clear. Perfect. Okay. So avoid conception for 2 years. It's false. You don't need to. Routinely require evacuation. That's true. You can't do conservative management for HMOL. Always you have to do suction evacuation because it's a pre-malignant lesion. You can't wait and see without doing anything. You have to do suction. So it's false. Suburethral bluish mass indicate metastatic tropoplastic disease. No, even local infiltration without metastasis can cause infiltration. So that's false. So answer for question number 3, true, true, false, true, false. Perfect. Question number 4 regarding true or false normal labor. Pain is a good indicator of strength of uterine contraction. It's false because uterine contraction indicator can't be pain because the duration, strength, interval can be an indicator for the uterine contraction strength. Because the pain is a perception by person to person. Some women might screaming, some women might crying, some women might smiling. That's depend on their perception. You can't say a woman smiling, she does not have pain. She is having pain, but she could tolerate. So the pain is not a good indicator to say the strength of uterine contraction. So it's false. Induction aim to complete the labor within 3 hours. False. Induction is artificially starting the labor, not to reduce the duration of labor. Induction of labor is if a woman does not start at the labor, we are starting the labor in an artificial manner. That is induction of labor. So induction, it's not to reduce the duration of labor. So it's false. Forceps cause more maternal injury than ventos. Yeah, of course, because in ventos, we just put over the baby's head and pull it out. So we don't need to use any extra space. Only we are pulling the baby's head and pull out. So forceps can cause more complication to the baby and vacuum can cause more complication to the baby, and forceps we are putting in addition to the baby's head laterally and pull it, so which can cause lateral damage to the mother's vagina. So forceps mother friendly and more damage to the baby. Vacuum mother friendly, more damage to the baby. Forceps baby friendly, more damage to the mother. So forceps cause more maternal injury than ventos. That's true. In induced labor, more analgesia are required than spontaneous labor. That's true. So you can ask what is the reason. This is a research finding. When you are inducing, patient will feel more pain because it's perception. Maybe a prolonged period and she's in the labor ward for a long time, which can be the reason. Yeah, that's true. In vasa previa, ARM should be done in theater. True or false? Yes, Haranya? What do you think? Yeah, if it is a vasa previa, means the fetal blood vessels are running over the membrane in the vagina, in the uterus. So when you rupture the membrane, bleeding from the baby will kill the baby. So vasa previa, you can't do ARM, always cesarean section is the mode of delivery. So it's false. So answer for question number 4, false, false, true, true, false. Question number 5. A 28-year-old female in her first pregnancy came to emergency department complaining of reduced fetal movement. What is the statement compatible to pathological CTGs? For this, you need to know FIGO classification of CTG. So in FIGO classification, there are reassuring features, non-reassuring features, and pathological features. Depend on this reassuring, non-reassuring, and pathological CTG features, we can categorize the CTG into 3. One is normal CTG, suspicious CTG, abnormal CTG. Okay, so we have 3 features. Depend on 3 features, we are classifying into 3 types of CTGs. Non-reassuring feature, reassuring feature, non-reassuring feature, pathological feature. Depend on this, normal CTG, suspicious CTG, and abnormal CTG. Okay. So what do you understand by reassuring feature? So if it is a baseline in between 110 to 160, it's reassuring feature. Variability in between 5 to 25, reassuring feature. Presence of acceleration, reassuring feature. Absence of deceleration, reassuring feature. So when you look at the CTG, if If your baseline is 120, good variability, no deceleration, their acceleration, then you can, all the features are reassuring features, then you can say normal CTG. If the baseline is less than 100, 110, but still in between 100 to 110 or 160 to 180, that is non-reassuring features. If the baseline is less than 100, it's abnormal feature. If baseline is more than 180, abnormal feature. So everything has different features and different category. So if it is all the features are reassuring, you can say the CTG is normal. If you have one non-reassuring feature, there is another CTG, 165 baseline, good variability, no deceleration, there are acceleration. So here rest of the features are okay, but the baseline is 165. It means she has one non-reassuring feature. Except that tachycardia, rest of the things are normal. You got it, Sachinta? So if you have one non-reassuring feature, then that CTG will be categorized as suspicious CTG. You can't say it's a normal CTG, obviously it's a suspicious CTG. If you have one abnormal feature or two non-reassuring features, then that CTG will be categorized as abnormal CTG. I'm telling another scenario. Baseline 185, variability 10, so it means in between 5 to 25, so 10. There are acceleration, no deceleration. What about this CTG? Baseline is okay, accelerations are there, no deceleration, but the baseline, baseline variability is okay, no acceleration. So there are acceleration, no deceleration. Only problem, baseline is 185. I told you, if the baseline more than 180, that is abnormal CT, abnormal feature. So if you have one abnormal feature or two non-reassuring feature, then that CTG will categorized as abnormal CTG. You got the point? So here, the baseline is 185. So she has one abnormal feature. So what is the type of CTG? This one. Pathological CTG. Or abnormal CTG. You got the point? All right. Okay. I'm telling another scenario. A lady CTG baseline is 165. Reduce variability for 50 minutes. There are accelerations, no deceleration. What type of CTG?
Non-reassuring.
Non-reassuring. Okay. Any other answers? Have you find any non-reassuring features for this patient? Baseline 165. Is it reassuring or non-reassuring or abnormal?
Non-reassuring.
Non-reassuring, because I told you from 160 to 180, non-reassuring. More than 180, abnormal. Less than 160, it's normal, reassuring. So this is 165. So one non-reassuring. Variability should be in between 5 to 25, but she's having reduced variability, less than 5 for less than 90 minutes. It's one of the non-reassuring feature. So now she's having second non-reassuring feature. There are acceleration, that is reassuring feature. No deceleration, reassuring feature. Even though she's having reassuring features, she has two non-reassuring feature. So two non-reassuring feature, then what category of CTG this one? Normal CTG or suspicious CTG or pathological CTG or abnormal CTG?
Suspicious.
So I told you, if it is suspicious, there should be one reassuring. If it is two reassuring or one abnormal feature, then it's pathological. So here she is having two non-reassuring. So obviously this CTG is pathological. Perfect. So don't worry, you can check that chart. There is a chart. You can go and get it, that chart in the theory class emergency session. Please go and check there. Or you can find it from my book. So that chart is there. So just try to memorize that chart. What are the reassuring feature? What are the non-reassuring feature? What are the pathological feature? Depend on that, you can simply identify what type of CTG it is. Okay. Clear? Perfect. So here, what statement compatible with pathological CTG? Absence of acceleration. Absence of acceleration, it's not pathological feature, right? So it's not, it's false. Fetal heart rate 175. If the fetal heart rate is 175, what is the feature? This one? Non-reassuring, because it's in between 160 to 180. So it's non-reassuring. So if it is a non-reassuring feature, one non-reassuring feature, that CTG call it as suspicious, not the pathological. Here they are asking pathological CTG. So if the fetal heart rate is 175, it's not, it's pathological, it's suspicious, it's not pathological. Fetal heart rate 105.
Reassuring feature 110 to 160.
110 to 160 is normal. So it's bradycardia, but still 110 to 100 is non-reassuring. Less than 100 is pathological. So it is non-reassuring feature. One non-reassuring feature. One non-reassuring feature. So that is suspicious, not the pathological. So it's false. Presence of late deceleration more than 30 minutes. Presence of late deceleration more than 30 minutes, it's a pathological feature. So one pathological feature hits pathological CTG. So that's true. Baseline variability 5 to 10.
It's normal. 5 to 25.
It's normal. Yeah, 5 to 25, it's normal. So if 5 to 10, it's reassuring feature. So it's not pathological CTG, it's false. So answer, false, 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 true, false. Carcinoma of the cervix. Squamous carcinoma is common. Yes, 90% of the cervical cancer is squamous. 10% is adenocarcinoma. That's true. Commonly metastatized to the superficial inguinal knot. False. Superficial inguinal knots are mainly getting drained from the external genital organ, not from the cervix. The uterine cervix is draining to the internal iliac vessels, internal iliac knot or external iliac knot, rarely external, but mainly internal iliac knot. But the labia, vestibule, the external genital organ mainly drain to the iliac knots. So here they have mentioned commonly metastasis is a superficial inguinal knot. No, that is internal iliac knots. It's false. COCP is a risk factor. It's kind of a weird question. Some examiners might say false, some examiners might say true. So I will tell the explanation why it is true. Then better if you have a question, you can think whether you want to mark it or leave it. Because when you give COCP has estrogen. So when the cervical epithelium is exposed to estrogen, squamocolumnar junction will move outside. When the squamocolumnar junction move outside, the transformation zone will move, because this HPV infection will occur in transformation zone. When transformation zone move outside, the infection can easily occur. So risk of HPV will increase with COCP. So indirectly, which can be a risk factor for cervical cancer. So it's a weird question. You can mark it as true. Arise from scamocolumnar junction. That's false. It's not from the scamocolumnar junction. It's from the transformation zone. Not from the scamocolumnar junction. It's false. Ureteric obstruction is a recognized feature. Yeah, that's true, because when it is a malignancy in the cervix which can spread to the lateral pelvic wall, so in the lateral pelvic wall, the ureter is going on, so which can infiltrate into the ureter, can cause obstruction to the ureter, can cause ureteric obstruction. So that's true. So answer for question number 6, true, false, true, false, true. Perfect. Question number 7, female coming with urge incontinence. What are the steps of management? So urge incontinence means something problem with the bladder muscles. Bladder muscle irritation which cause unnecessary contraction of detrusor muscles which cause urination in inappropriate time. So your aim of management is to suppress the bladder muscles activity. You can paralyze the bladder muscle, so you can block the bladder neuromuscular junction by using cholinergic blockers, so beta-3 agonist with mirabegron. So the surgery for the urge incontinence will be the last option, and it's not that much effective. Either you can do resection of some muscles to reduce the power of bladder muscle contraction, so myectomy, cystoplasty, or urinary diversion. You can take the ureter and just anastomose to the rectum or anal canal, rectum. So then, like a feces, urine will come out. So because the anal sphincter is intact, once it's full, anal sphincter will dilate and urine will come out. Then it will full come out like that. So that is urinary diversion. So those are the last options. So the initial options are medical management. So bladder trill or pelvic tree training or bladder tree training. Yeah, that's true. That is one of the first line management. Pelvic floor muscle exercise to strengthen the pelvic floor. Pelvic floor muscle weakness will not cause urge incontinence. As I told you, urge incontinence is due to detrusor muscle overactivity. Stress incontinence is due to pelvic floor muscles weakness. So pelvic floor muscle exercise is mainly for the stress incontinence. Bladder trill or bladder tree training is for the urge incontinence. So bladder trill through oxybutynin. Oxybutynin is a cholinergic receptor blocker. So neuromuscular blockage of detrusor muscles will reduce the urge incontinence. That is true. Pelvic floor muscle exercise false because that is for the stress incontinence. Imipramine, yeah, that's true because which can cause reduced activity of the detrusor muscles, and mid-urethral tape procedure, that is for the stress incontinence, not for urge. Answer for question number 7, true, true, false, true, false. Question number 8 regarding misoprostol. Misoprostol is a prostaglandin E1. Prostaglandin E1, which can cause uterine contraction. We are using this misoprostol for termination of pregnancy, or maybe if it is a postpartum hemorrhage to make the uterus to contract, we can insert the misoprostol. Using misoprostol for the induction of labor to stimulate the uterine contraction is not recommended in UK as well as in Sri Lanka, because which can cause severe uterine contraction and fetal distress. So we are using prostaglandin E2 for the induction of labor. E1 is not for the induction of labor. So misoprostol, when you are taking the misoprostol, which can cause gastrointestinal side effect. So diarrhea is a side effect, that's true. Is a synthetic analog of prostaglandin E1? Yeah, that is true. Tablet strength is 25 macrogram. No, one tablet is 200 macrogram, not 25. It's false. Contraindicated in coagulation disorder, false. You can use it in coagulation disorders as well. It's false. Used in medical management of incomplete miscarriage, that's true, because when you insert the misoprostol, it will make the uterus to contract to expel out the retained product. Yeah, that's true. So answer for question number 8, true, true, false, false, true. Bacterial vaginosis produce gray color vaginal discharge. That's true. So how to diagnose the bacterial vaginosis? Amsel criteria. What are those 4 criteria in Amsel criteria? Yeah, anybody please? Anybody? Amsel criteria? Yeah, presence of clue cells in the microscope.
Fishy order with addition of K.
Fishy order discharge or gray color discharge.
pH above 4.5.
pH of the discharge of vagina more than 4. And one more.
White gray.
Yeah, gray color discharge, glue cells, pH more than 7, and when you add KOH to the discharge, you will have fishy odor, release of ammonia. So that is 2 out of 4. It's 3 out of 4. It's diagnostic, right? So you can diagnose with the Amsel criteria. So here they have mentioned produce gray color vaginal discharge. That's true. It's caused by Gardnerella species. Here, Gardnerella is one of the species. That's true. Is suspected by clue cells. Yeah, because clue cells is one of the criteria. That's true. Predisposed to preterm delivery. Bacterial vaginosis is risk factor for preterm delivery. That's true. Is treated by erythromycin. False, because it's gram negative. Anaerobes. So, what is the treatment? Anaerobes, what is the treatment? Very good. Metronidazole. Very good. Metronidazole is the treatment. So true, false. Question number 10. Anovulation results from prolactinemia. That's true, because I told you if it is an anovulation, there could be a problem in the hypothalamo pituitary ovarian axis. If you have problem in the hypothalamus, can cause anovulation. If you have problem in the ovary, can cause anovulation. Or if you have problem in the pituitary, can cause anovulation. In addition to that, there are 3 hormones can impact the ovulation from the outside. One is prolactin, second one is thyroxine, third one is insulin. Hyperprolactinemia, excessive prolactin can inhibit the pituitary, inhibit the ovary, and can cause anovulation. This is a natural thing, because when a woman breastfeeding, she should not become pregnant. She can't become pregnant. So that's why the code created that. So when she is breastfeeding, prolactin level will be high. So prolactin will suppress the ovulation. So she can't become pregnant. Once the baby grown, once she stop breastfeeding, prolactin level will come down. Then again, the pituitary will start to act. The ovulation comes, then she can become pregnant. Otherwise, what will happen? Once she delivers the first baby, next month, she will become pregnant. Next baby, after 1 month, she will become pregnant. So then who is going to breastfeed the baby? So to make sure the baby is breastfeeding, what the goat did, while she is breastfeeding, prolactin will suppress the ovulation. She can't become pregnant. Okay, so prolactinemia, true. Asherman syndrome. So in Asherman syndrome, what is the problem? Here, fibrosis in the endometrial cavity. So as it is a fibrosis, obviously there is no endometrium. So during the menstrual cycle, this endometrium will not shed off, so she won't have bleeding. So she will have amenorrhea. So this woman will present no bleeding, but obviously she will ovulate. The ovulation is occurring, but she's not having bleeding because there is no endometrium to shed off, no endometrium to bleed. So problem is not with the ovulation, problem is with the uterus. So in Asherman syndrome, obviously she will have ovulation, but she will have amenorrhea. So it's false. Kallmann syndrome, yes, because Kallmann syndrome problem with the pituitary, hypothalamus. Hypothalamic developmental problem. So without hypothalamus, can you have GnRH? No. Without GnRH, can you have FSH? No. Without FSH, can you have follicular stimulation? No. Without follicular stimulation, can you have ovulation? No. So if you have problem with the hypothalamus or pituitary or ovary, you will have amenorrhea. So Kallmann syndrome, true. Uterine agenesis. Uterine agenesis. In uterine agenesis, again I am telling, problem is in the uterus, absence of uterus. Without uterus, you will not have bleeding, but there is no problem with the ovary. Ovulation will occur, but she will not have bleeding. So patient will have amenorrhea, but ovulation will occur. So uterine agenesis and ovulation results false. IUCD in situ. If there is an IUCD, it won't affect because IUCD, no hormonal effect. There is no effect on the ovary. There is no effect on the ovulation. The contraceptive effect of IUCD is different. Anti-sperm activity and inhibit the implantation, not the anovulation. The hormonal contraception causes anovulation because that will suppress the pituitary, that will suppress the ovary, ultimately which can cause contraception. But IUCD, it's not due to anovulation. That's a different. So answer for question number 10, true, false, true, false, false. Done. Do you have any question? Do you have any questions? Okay, so if you don't have questions, so I'm repeating, so please go to the More Education, so you can just do the exams, see your marks, download your papers, do the exams twice, two attempts, 3 attempts, you can compare your marks. If you have any question, you can contact me or my coordinator. So we'll meet in the next class, so you can have a nice sleep. Okay, good night. Thanks for attending the class. Bye.